Greetings, fellow PAs. Welcome to this presentation. It's titled Refer or Keep? That is the question. Musculoskeletal injuries and fracture management for primary care. Hi, my name is Amelia Duranstanton. I've been an ortho PA since 2010, but I've been a PA since the year 2000 as a primary care. I received my doctorate in orthopedic surgery through the Army Baylor program, and I've been practicing orthopedic surgery since then. So thank you for listening in to this important topic, one of my favorites. This is my disclaimer. My views are mine and do not reflect the official policy of the Department of the Army, Department of Defense, or the U.S. government. The purpose of this presentation is to educate providers on musculoskeletal injuries and fracture management, what to refer, and what can be managed at the primary care level. These are our objectives. I want you to learn general principles of musculoskeletal injury assessment, understand general fracture principles, when to refer out fracture care, understand management of specific fractures, recognize osteoporotic fractures, learn the proper use of a splint versus a cast, identify commonly used casting materials and when to use them, identify proper cast application and removal, and describe appropriate patient education with especially when casting and splinting. This is our outline. Why this topic? Injury assessment, such as signs and symptoms, compartment syndrome, strains, sprains, and fractures, different types of fractures, whether to refer them or to keep them, casting and splinting. We'll do check on learning, provide you references, and because this is recorded, we won't have a chance to discuss. However, contact us if you have any further questions or anything to discuss. So why is this topic important? Well, musculoskeletal complaints are the second leading cause of patient visits in primary care. This is accounting for 30 to 40% of such visits. Fracture-related visits constitute a significant portion, with wrist fractures being the most frequent at 30%, followed by collarbone fractures at 15%. Primary care providers manage a substantial number of these cases, and emphasizing the importance of early and accurate assessment to prevent complications and long-term disability. Fracture management requires an understanding of different treatments, especially the primary care providers must recognize when to refer patients for specific injuries. And of course, ortho-rocks. So the general principles, what to refer, how can you stabilize them, and what to keep, how to treat, what you manage on your own. You may be in an isolated location where you're the only provider, or you may be having difficulties evacuating, or there's maybe weather problems, or you're not able to evacuate them as soon as you can. And so these are circumstances where you need to determine also what you need to do when you're unable to refer someone in a timely manner. First thing to do is injury assessment. You need to accurately assess musculoskeletal injuries, especially it is crucial for appropriate management. Signs such as swelling, deformity, and loss of function indicate potential fractures, while severe pain with neurological or vascular symptoms may suggest compartment syndrome. So you're differentiating between sprain, strain, and also this allows any fracture allows for targeted treatment strategies. So what do you do when you're assessing the injury? Of course, always start with your ABCs. First, your primary survey, what are the obvious injuries? And then conduct a secondary survey, catch more subtle musculoskeletal injuries. So during your injury assessment, what do you need to do? Utilize a systematic approach. Before you touch the patient, inspect it first. Inspect from top to bottom, or and then once you're inspected, now you can palpate, but gently. Check for neurovascular status, sensation, and pulses. And then when you're assessing the injury location, assess joints above and below the injury. Next is range of motion. If the patient is awake, do active range of motions. What can they move in their current situation? But don't make them move that worsens their condition or worsens their pain. And then passive is when you are the one that's conducting the range of motion for the patient, but don't force. Again, don't make the injury worse. And then, of course, if you're able to, do some strength testing. Once you've done your ABCs, primary and secondary surveys are complete. Is it a stable patient? Go ahead and splint whatever the injury is. If it's an unstable patient, you may need to load and go and may have to splint and route. Utilize this acronym whenever you're assessing the patient. DCAP, BTLS. Where are the deformities? Are there contusions? Are there abrasions? What about punctures? Do you see any burns? Are they tender? Are there any lacerations? And do you see any swelling? For signs and symptoms, check for pain and tenderness. Are there deformities and deformed angulations? Is there crepitus? Is there swelling? Bruising? Do you see an open fracture? Are the joints locking? And is there neurovascular compromise? While you're looking for signs and symptoms, be specifically looking for compartment syndrome. This is a medical emergency that requires urgent intervention. The symptoms are pain out of proportion, pallor, paresthesia, pulselessness, and paralysis. How do you diagnose this? It's a clinical assessment and intracompartmental pressure measurement. Treatment is fasciotomy to relieve the pressure. So increased pressure in a closed compartment, it occurs with long bone fractures. This is the femur, tib fib, radius ulna, the humerus, and also small compartments like the foot and hand. Like previously stated, this is a surgical emergency. The compartment needs to be opened to avoid loss of limb. Increased pressure equates to loss of blood oxygen supply and becomes resulting in tissue death. And it can progress quickly. It's important to reassess neurovascular status frequently. For neurovascular compromise, check for pain, pallor, pulselessness, paresthesias, poikilothermia or cool sensation, paralysis, and puffiness or edema. Now let's move on to strains. Strains are injury to the muscle or tendon due to overuse or overstretching. There's microscopic muscle tearing due to excessive force, stretching, and overuse. Signs and symptoms are hemorrhage, swelling, tenderness, pain with isometric contraction, and muscle spasm. Sprains. These are injuries of ligamentous structures like a rubber band from twisting and possible joint instability. The signs and symptoms of sprains are rapid swelling, pain with range of motion, decreased range of motion, and bruising will likely travel distal to the injury, which is a later finding. These are the gradings for sprains. The first one is mild, no loss of joint function. There's edema. There's 25% fiber involvement, and it can occur with normal activities. Then there's moderate. Is it partially torn? And there's weakness and ligament strength. And the third level is a complete tear based on sign of popping, or symptom, joint laxity, and may require surgical repair. It can be as severe as a fracture. So what can you do for sprain and strain? So these are your treatment options. You're aware of RICE. Rest, make sure that the extremity is resting with minimal activity. Make sure it's being iced. Utilize crutches or other immobilizing devices. Compression and elevation. Also, prevent joint stiffness and do some range of motion exercises. Now let's talk about fractures. So these are the general principles of what to refer and how to stabilize them, and what to keep, how to treat what you manage on your own. So fracture management, refer, keep. Fracture is basically a break in the continuity of the bone. Primary care providers must recognize which fractures require orthopedic referral. Open fractures and those with significant displacement require specialist care, whereas simple, non-displaced fractures can often be managed with immobilization and follow-up. What are your indications for referral? Here they are. Is it an open fracture? Is it a displaced fracture requiring surgical intervention? Is the fracture intra-articular? And is there neurovascular compromise? The fractures that you can manage in primary care are those that are stable, non-displaced fractures, simple fractures of fingers, toes, and distal extremities, and some pediatric fractures with proper follow-up. Here's an acronym that you can use. It's called old acids. Is the fracture open or closed? Where is the location? What is the degree of angulation? Is there an articular involvement? Is there comminution, and what type? What is the intrinsic bone quality? Is there displacement? And is there soft tissue injury? These are the signs and symptoms of fractures. There's pain at the site of injury. There's swelling and tenderness, crepitus, and deformity. There's loss of function, ecchymosis, paresthesia, and distal pulse is not be present. It is important to know fracture descriptions, because not only for yourself, but also when you're referring to an orthopedic surgeon or for evacuation, you need to explain what type of patient fracture it is. So these are the ways that you can articulate to whoever you are referring to, whether that be an ortho PA or an ortho surgeon, what you see on your end. What is the orientation of the fracture line? And look at the pictures there. A is transverse across there, and is it oblique, which is angulated? Is it spiral? Is it throughout the circumference of the bone? Is it comminuted? Is it in different broken bones? Is it segmental? Is it a torus or a buccal fracture like in kids? Is it a green stick fracture? Again, like in children. So let's go through each one of these. So as you can see from that picture, this is a transverse fracture. It's straight across the bone, usually due to direct trauma, like a motor vehicle accident. This is an oblique fracture. It is an angle across the bone. This is a spiral fracture. It's twisted around the shaft of the bone like a twisting injury. A comminuted fracture, it's a bone that's splintered into more than 3 fragments. A green stick fracture. One side of the bone is broken and the other is bent. This is mostly seen in children. As long as the bone is kept rigid, healing is usually quick. This is a depressed fracture. The fragment or fragments are driven in, as can be seen in this depiction where the fractures of the skull. Compression fracture. These usually occur of falls from a standing height or from a height. So bone collapses in on itself, seen in the vertebra fractures. An avulsion fracture is the fragment of bone pulled off by the ligament or tendon attachment. This image shows an impacted fracture. It's a fragment of one wedged into other bone fragments, usually from a foot injury or fall on outstretched hands. Now let's talk about open fracture. The skin is broken. The fragments of the bone will penetrate through the skin. Now let's help you decide whether to refer or keep. What are the circumstances that you need to refer or the times that you may be able to keep? For metatarsal and phalanges, those that you can keep have minimally non-displaced fractures. You can put a short leg cast and have them non-weight bearing for 4 to 8 weeks. You can utilize a splint, such as a posterior slab, and you can have or not have a stirrups for a week. So the treatment is casting, short leg for 2 to 6 weeks, non-weight bearing for 2 to 8 weeks, and then active range of motion for approximately 4 weeks. Then refer them to physical therapy for ankle strengthening and proprioceptive training. What about ankle fractures? What can you keep? Avulsion fractures and some Weber A type, some Weber B fractures, you need stress radiographs. Treatment is splinting, posterior slab plus or minus stirrups for a week. You can also put them on a cast, short leg for about 2 to 6 weeks, non-weight bearing 2 to 8 weeks, with active range of motion for approximately 4 weeks. Refer to physical therapy for ankle strengthening and proprioceptive training. The ankle fractures that you need to refer. When you're looking at the radiographs, you see bi- or trimalleolar fractures, bimalleolar equivalency fractures, talar subluxation, articular impaction, syndesmosis disruption. The treatment is to reduce the fracture and splint, putting a posterior slab with stirrups. And then significant joint involvement, obtain post-reduction radiographs. These are radiographs that you can see where they are bimalleolar fractures. What about clavicle fractures? The ones that you can keep are shaft type with minimal displacement and shortening. You can put them on a sling or a figure eight for 4 to 6 weeks. Send them to physical therapy for range of motion and strengthening exercises. The ones that you need to refer are comminuted, shortened, and distal proximal type, and then put them on a sling. These are the different types of clavicle fractures that you may see in the radiographs that you order. Now let's talk about proximal humerus fractures. Their mere classification helps determine the treatment. They can be one part, two part, three part, or four part. So for proximal humerus, majority need close follow-up with orthopedics, even if non-displaced initially may displace later or present with later stage rotator cuff issues. You can put them in a sling or sling and swab. The ones that you need to also be cognizant about are those with osteoporotic fractures. And these are some radiographs that can see that you can see those proximal humerus fractures and the treatment for it on the bottom right. Now, let's move on to the distal radius. This is the most common orthopedic injury with a bimodal distribution. For younger patients, usually due to high energy. For elderly patients, usually from low energy falls. How do you manage these? If it's non-displaced extra-articular, well-reduced extra-articular with good bone quality, with well-molded cast or splint. These are different eponyms of distal radius fractures. A die punch is a depressed fracture of the lunate fossa of the articular surface of the distal radius. A Barton's fracture is a fracture dislocation of the radiocarpal joint with intra-articular fracture involving the volar or dorsal lip. The chauffeur's fracture is a radial stylet fracture. So whenever you're seeing distal radius fractures, understand the energy of how they were injured. So as you can see with the Colles fracture, it's an outward energy. And for the Smith's fracture, it's inward. These are some more artistic showing of how distal radius fractures are sustained. As you can see, that was a push injury, and you can see where the bones are fractured there. Different types of fractures on the distal radius. And then showing the reduction of a Colles fracture on the bottom right. So you get used to seeing what radius fractures look like. See the impactions there from the energy sustained from a fall. And there's different surgical options that are used, the X-fix, and other options there depending on the type of patient and also the type of energy. And here's a better picture of the treatment options provided. So how do you treat? What are your options? You can splint and refer. You can splint and cast later. You can reduce and splint. You can cast and manage, and then reduce and cast. Many of these is based also on your comfort level in treating these patients, and also whenever you're calling your orthopedic surgeon or ortho PA, what is the experience of that orthosurgeon and what they want to do has a big impact on how these patients are treated. So make sure that you get their guidance right away. Now let's talk about scaphoid fractures. Scaphoid is the most frequently fractured carpal bone, 50% of wrist injuries. The prognosis, the incidence of avascular necrosis with fracture location, the proximal 1/5 is about 100%. The proximal 1/3 is about 33%. When you're assessing the patient, they usually have wrist pain after a fall. You can either put them in a splint versus a cast for 2 weeks, repeat the radiographs. If there's no fracture, continued snuff box pain and pain on pronation, order an MRI. You may need to refer out and put them in a thumb spica splint or cast. As you can see here, that's where the scaphoid is, and you can see the scaphoid fracture here in between. You can see the thumb there and then the radius here. And when you're examining the patient, you can see swelling and tenderness in that area, snuff box, and are typical with a scaphoid fracture. So have a high index of suspicion that they have a scaphoid fracture if they have the snuff box tenderness, even though the radiographs may look normal when they first present. Now let's talk about osteoporosis. So calcaneus and talus fracture, what to keep? None, short leg splint, non-weight bearing, complicated, and high low-term pain rate, typically higher energy fractures. Tibial shaft fractures, what to keep? There's very few of them. Most you put in long leg splint and refer. Minimal allowance for malalignment. Trend is to stabilize surgically for early range of motion. What are the exceptions? You could have a patient that has a toddler fracture. Make sure you obtain phone consult of orthopedist and listen to the mom. I had a patient I had the toddler fracture. Even though the radiograph looked normal, the mom knew that there was something not right with the child because they were crying and inconsolable. And then elderly, non-ambulatory, they're minimally displaced, put them in well-padded long leg cast. For the femur shaft fractures, usually non-operative, only in the baseline, non-ambulatory or severely unhealthy. Non-displaced, put them on non-weight bearing for 8 to 12 weeks. If it's displaced, non-weight bearing is essentially lifelong. For operative, they are provided with OREF, or open reduction internal fixation via plate and screw construct versus intramedullary nail. For hip fractures, for femoral neck, these are usually non-operative. The treatment is only in the baseline non-ambulatory or severely unhealthy. If it's non-displaced, non-weight bearing to 8 to 12 weeks. If it's displaced, non-weight bearing is essentially lifelong. For operative patients, close reduction and percutaneous screws, hemi versus total hip arthroplasty. Hip fracture that are inner trochanteric, non-operative, only in the baseline non-ambulatory or severely unhealthy. Those that are non-displaced will be placed in non-weight bearing for 8 to 12 weeks. If it's displaced, non-weight bearing is essentially lifelong. For operative, they are treated with intramedullary nail versus dynamic hip screw type device. For humeral shaft fracture, it's a complex fractures. Acceptable limits are less than 30% anterior, less than 20% varus valgus, less than 3 centimeters shortening, usually associated with radial nerve palsy. Usually refer most of these out with a coaptation splint plus or minus a long arm splint. Definitive treatment are varied. There's hanging arm cast, the Sarmiento, or the open reduction internal fixation, or intramedullary nail. Fractures about the elbow. What do you refer? Those supracondylar, intercondylar, olecranon, interarticular, displaced, elbow dislocation. If elbow dislocation, reduce and put in long arm splint. For radial head and neck fractures, isolated minimally displaced less than 2 millimeters fractures with no mechanical blocks, treated with long arm splint for 3 to 7 days with an early range of motion, and consider aspiration if needed. The Mason classifications are type 1, minimally displaced fracture, no mechanical block, to rotation, interarticular displacement is less than 2 millimeters. For type 2, displaced fracture is greater than 2 millimeters or angulated, possible mechanical block to forearm rotation. Type 3 is comminuted and displaced fracture, mechanical block to motion. And in type 4, it's Hotchkiss modification with a radial head fracture with elbow dislocation. All right, so now that we've talked about the different types of fractures, let's talk about casting and splinting. Casting and splinting play critical roles in fracture management. Splinting is often used in acute settings to accommodate swelling, while casting provides definitive immobilization. Understanding the difference ensures that you provide the appropriate care for the patient. Now let's review some casting. What does casting do? It provides complete immobilization. It's used for stable fractures and long-term immobilization. There are different types, plaster versus fiberglass, and there needs to be proper application and removal techniques. So casting is a mainstay of treatment for most fractures. Joint above and a joint below is included when casting. Avoid pressure points, utilize proper molding, and cast indentations. Appropriate padding is needed to protect the area and also make sure to decrease pain. You need to put more at the bony prominences and not too much at the fracture site. And also consider the skin wounds. Now let's review some splinting techniques. What's the purpose of splinting? It allows for swelling and initial stabilization. Splinting is used for acute injuries before casting. It reduces pain, reduces bleeding and swelling. It prevents further soft tissue damage and prevents vascular constriction. What do you splint? You splint fractures, dislocations, and tendon ruptures. There are different types like posterior, sugar tongue, and volar. Now let's talk about the advantages and disadvantages of casting. The advantage is that it's more effective immobilization for most fractures. The disadvantages are requires more skill and time to apply. It also have a higher risk of complications if not applied properly. But still, casting is the mainstay of treatment for most fractures. Now let's review the advantages and disadvantages of splinting. The advantages are faster and easier to apply. They can be static or dynamic. They are non-circumferential and allows for natural swelling. They're easier to remove, and they allow regular inspection of the injury site. What are the disadvantages? There's lack of patient compliance because they are easy to remove. It could cause excessive motion, and they are not for definitive care. But remember, splinting is the preferred method of immobilization in the acute setting. Whenever you're either doing casting or splinting, make sure you have all of the supplies available and get them ready before you start getting the anything prepared, and also make sure that you assess the patient for their pain levels and also make sure that you are giving them something for that pain. So the supplies that you need are the stockinette, the padding material, the cast material, Make sure you have plaster. Plaster is cheaper, long shelf life, easier to work with, but it may be fragile, disintegrate in water. The fiberglass is more durable, it's lighter, it dries quicker, there are multiple colors, and it's water tolerant. And there are others that are newer synthetic materials. Remember, it's better to have too much materials as opposed to not enough, especially when you start treating the patient and preparing for the cast or the splint. And also try to have an assistant with you, because once you start getting in there and you need something, you can't just leave and come back. So if you're able to have an assistant, or in the military, have a medic with you or an ortho tech. So these are the procedures. First, you apply the stockinette, protect the skin and provide smooth edges. Apply the padding, protect the bony prominences, allows for swelling. Wet the casting material, use warm water. Hot water hardens faster, and the cold water it takes too long for it to harden, and squeeze out the excess water. Then apply splint or cast. Now this is very, very important. The patient instructions, these are crucial. Provide verbal and written instructions. Don't forget profile for military. And keep injured limb elevated in ice for about 15 to 30 minutes. Make sure they know about warning signs, such as numb extremity, inability to move extremity, discoloration, cold, and increased pain. Tell them to avoid getting it wet completely with plaster. They can use a hair dryer on cool setting if fiberglass. Also consider giving them antihistamines, because it does get itchy in there and they want to take it off and it becomes uncomfortable. Time to follow up and length of immobilization are extremely variable. It's depending on the site of the injury and the treatment, the type, the stability of the injury, the patient characteristics such as their age, accessibility, and their compliance. And then follow up. Most splints and casts have initial follow up within 1 to 2 weeks after the application. And most fracture guidelines requires about 6 to 8 weeks for healing, but all injuries must be assessed and followed up on an individual basis. So let's talk about the complications of immobilization. We talked about compartment syndrome before, even before these treatments, but it can happen with casting and splinting. Ischemia, it could also cause a heat injury, pressure sores and skin breakdown, infection, dermatitis, joint stiffness, and neurological injuries. What are your take-home points? You will see fractures. Know your comfort level and when to refer. Splint acutely and with active swelling. Utilize variety of materials. Know what you have and be comfortable with it. And educate your patients. Now let's do a little bit of check on learning. The first one is, in general, when should a splint be applied to a fracture in lieu of a cast? A, in the acute presentation. B, highly swollen extremity. C, compromised skin. D, all of the above. Or E, none of the above. All right, so the answer is all of the above. So in general, a splint should be applied to a fracture in lieu of a cast in the acute presentation, highly swollen extremity, and compromised skin. Now let's review question 2. Which fracture, when obtained in an adult from a simple fall, does not meet criteria for osteoporosis? Is it A, femoral neck fracture? Is it B, scaphoid fracture? Is it D, correction, is it C, hip intratrochanteric fracture? Is it D, L2 compression fracture? E, distal radius Colles fracture? Or is it F, comminuted, forepart, proximal humerus fracture? And the answer is B. The fracture that when obtained in an adult from a simple fall does not meet criteria for osteoporosis is the scaphoid fracture. Now review question 3. Which metatarsal fracture is easily treated by a primary care provider? Is it A, Jones fracture? B, fifth metatarsal avulsion fracture? C, Lisfranc fracture? D, Martin fractures? Or is it E, widening of the first inner metatarsal web space? The answer is B. The metatarsal fracture that's easily treated by a primary care provider is the fifth metatarsal avulsion fracture. Now let's do question 4. What are some complications with elderly distal radius Colles fractures? Is it continued fracture collapse? Is it carpal tunnel syndrome? Skin tears from fall or from reduction? Is it loss of range of motion? Or is it profound dexterity achievement after cast immobilization? The answer is D, loss of range of motion. Let's do question 5. Which clavicle is a good candidate for non-operative management? Is it A, looks like it's broken in two different places, comminuted? Is it B, it's displaced there? And then the C, midshaft. And then D. And the answer is C. This clavicle fracture is a good candidate for non-operative management. These are my references. So thank you for taking the time to listening to this presentation, and I hope that you got something out of it, something a refresher for some of you. And there's some of you also that this may be the first time that you may be learning these, but I hope it helps you not only in preparing for any of your tests or quizzes, but for also in real world situations when you are deciding whether to refer or keep in managing fractures in the primary care setting. Thank you and have a great day.